well. We're going to be popping links into the chat in terms of the forum and the website and the NHS Futures platform as we're mentioning things as we go through this morning's session. So if we move on to the next slide then please, Sonia, and if you've pressed record, I can see we're already recording. So today's agenda then, lovely. So this was published for you all. If you can stay with us, obviously we're together for the next 2 hours. You'll notice that the chat function is enabled. We're really looking forward to hearing from you in terms of your thoughts in response to the speakers' shared information, maybe news on successes and challenges, and any questions that you'd either like a response on in the chat or we can put to the speakers during the Q&A or at the end of each speaker's slot. So we will collate a Q&A document with responses and we'll publish that alongside the slide packs as well with the link to the recording. So gentle reminder at this point just to please remain muted to allow the focus to be on the speakers and their content to disseminate this information to you all today. So Marina and I will begin with the officers update then, followed by HQIP, NHS England, and then we've got John Ford from the St Mary's University of London that's coming to speak with us all today about engaging with our community, about a funded research project in equity in QI. We'll then move on to hear from NICE, and then we're going to share with you some preliminary outputs from Clinical Audit Awareness Week last week with a full evaluation of the NQICAN Lunch and Learns being shared at the 20th of September open meeting. And then finally, we'll hold a Q&A session before closing at 12. So if we move to the next slide, please, Sonia. Sonia's our NQICAN comms lead and she's supporting us all today with today's event. So as always, before we launch into the speakers' presentations, just wanted to reach out to you all again just to check in. There's a lot of health and wellbeing support out there to access if needed. We always say in the open meetings, just take 5 minutes at 12, step outside to catch your breath, just pause before you move on with the rest of your day. NHS employers have got a health and wellbeing network. We've got the link here on the slides for you, and they've also got a fantastic toolkit for individuals to use, but also it's a great resource really for you to support your colleagues and maybe also your teams. And it's also worth mentioning integrated care boards as well, because they now offer a wealth of resource and free to attend events. So please do access their websites for more information. And we'll move on then, I think, to start the officers update. So I've got some slides to share with you to begin with, and then I'll hand over to Marina so that she can talk to you about some aspects of her role as well. So on to the next slide. Key points then that we want to cover with you today really, and just to add at this point that the slides are prepped so that they act as a standalone information source on the forum and website as well for anyone who can't join. And we have had feedback that some people don't want to listen to the recording, they just want to access the slides, so hence why they do tend to include a little bit more information for you. The forum that we'll refer to throughout, for those not familiar with the NQICAN network and sharing forum, we'll pop links to in the chat. Fantastic platform and resource, allows our community to link in, network and share and learn together as well. If you're not yet a member, take that away as an action from today because we'd love to see you join us on there. We're going to update you on what we've been undertaking since the last quarterly meeting held back in March, in particular Clinical Audit Awareness Week, our improvement priorities, touching on the regional networks and highlighting some events, recap on our pledges, and then Marina will update us on some governance and financial aspects of NQICAN before we move to questions. So if we move on then, just highlighting this slide again that we normally share with you, just to explain the difference between the open meeting and your regional meetings. Open meeting today is all about cascading that information out to you all for you to take back to your organisations so that we can improve care for our patients and service users, but also taking it into your regional meeting so that you can actually then discuss together with the provider organisations that are in your integrated care system on successes and challenges and what this means to your local communities in terms of taking some of this information forward. So if we move to the next slide then please, Sonia. So touching on Clinical Audit Awareness Week here, but we'll touch in a little bit more detail towards the end of the meeting. So held last week, and what a week it was. It was 10 years on from it first being held, and it has really evolved in that time. Towards the end of this meeting, we'll share some initial outputs with you, and as always, a full evaluation of the lunch and learns at the September open meeting. So it's worth a mention at this point that we do continue to share and learn through year. It's not just a touch point that week in time, and our pledges and commitment to make health and care even better by improvements as part of clinical audit and wider QI agenda. We do it every day, and we've got to continue to share, learn and celebrate as we did last week in Clinical Audit Awareness Week as we move through the next year and beyond. So I'll leave it there at that point because we're going to talk to you a little bit later on as well. So if we move to the next slide, then we can talk to you about what we've been doing since March. So it's been really busy, but just to cover some key points in a little bit more detail, then we were very busy in that run up to Clinical Audit Awareness Week with planning those daily lunch and learns on the forum and supporting HQIT with the Clinical Audit Hero Awards. We've held regular steering groups and HQIT meetings, and we've continued to meet with regional network chairs to discuss how the networks need to reshape to align with the Integrated Care Board changes. We've been working on the improvement priorities through the officer roles and the co-opted members and the task and finish groups, some of which are the webinars that we're planning with the Academic Health Science Network around innovation and adoption of medtechs, and our collaboration with the transformation team as well in support of NHS impact and taking action on national clinical audits. And I won't say much more there because obviously we're going to hear from Helen later. On behalf of NQICAN, we've attended some more specification development meetings, and these are where a new audit's been identified for commissioning or a current audit is due for commissioning. NHS England will convene a meeting with key stakeholders to review and shape that audit, and NQICAN have a seat at that table. We've got that voice that contributes to these discussions, but we want to strengthen that voice a little bit further and ask for feedback from our clinical audit community on particular national clinical audits and outcome review programs before we attend those SDMs, as they call them, to ensure that we do take that considered approach to feeding in anything relevant to influence that commissioning process for the benefits of our patients and service users from that clinical effectiveness teams, participating organisations and that patient voice. So watch out for any comms where we might circulate to ask for some feedback. NHS England's Executive Quality Group, Clinical Audit Subgroup, sorry, that's the EQG CASG that we sometimes hear referred to, and also the National Clinical Audit Implementation Group. NQICAN have continued to attend those meetings, and Helen may touch on those a little bit further in the NHS England update later. We've also been working as part of a working group looking at the National Clinical Effectiveness Strategy, which is being led by Vin Dawakar, the Medical Director for Secondary Care and Transformation at NHS England. And some of the NQICAN core members met with NHS England for a focus group looking at a number of clinical effectiveness programmes and how we currently engage with them and how we should be going forwards to feed into the development of that national strategy. And we will keep you all updated on any progress with information as we're able to share that with you. We've held 2 of a series of 3 webinars looking at taking action on national clinical audits, and we'll hear more from Helen shortly on this. And all of that activity that's been undertaken by our core and non-core members has all been driving our forward plan. So we'll move on to the next slide just to look at a few of those aspects in a little bit more detail with you. So anyone who's not yet read the NHS Delivery and Continuous Improvement Review and its recommendations, please do take some time to access it and read it. NHS Impact is here, and we all need to be supporting our organisations to deliver on the 3 recommendations that you can see outlined here. We heard from Vin Dawakar, the MD for Secondary Care and Transformation last week during the second of a series of 3 workshops about taking action on national clinical audit. If you missed either of the first 2 workshops, you can access the recordings via the NHS Futures platform, and we'll make sure that link goes into the chat for you to register to join if you've not yet joined that. We heard from John Ashcroft as well, the Director of Pathways at NHS England, at Friday's Clinical Audit Awareness Week 23 Lunch and Learn, and John touched on the NHS impact there as well. So again, as soon as we can get the links to the recordings there onto the YouTube channel for you via the forum and HQIT website, please do access John's talk at the Lunch and Learn as well. So aligned to the NHS impact is the recently launched NHS Futures Knowledge and Sharing Hub for taking action on national clinical audits, and Helen's going to talk to us about that later on. So I'll move on to the next slide, Sonia, just to look at some of the task and finish groups. So Sarah Chesil is one of our co-opted members that's working on the task and finish group, looking at innovation and adoption of the medtechs and the measurement of those through clinical audit and wider QI. So we're planning a series of 3 webinars working with the academic health science networks, and we discussed this work stream at the December 22 open meeting. And the first webinar date is now confirmed as the 5th of October, 10 AM to 12 PM on Teams. Booking will be available via Eventbrite once the advert is published, which will be coming out via the Academic Health Science Network very soon. 2 provisional dates for workshop 2 and 3, just so that we're sharing these with you now. Hopefully they'll be finalised soon, but the 30th of November 23 and the 30th of April 24. You can see on the slide that the first webinar will apply to a number of audiences, so it's worthy of booking on. Please watch out for that comms coming. Once it comes out, we'll send it out via the forum and your networks. But for anyone not yet in touch with their local AHSN, their Academic Health Science Network, we've got this map here. You can see who your local team is so that you can get in contact. So if we move to the next slide then, Kerry Feldbauer, one of our other co-opted members, is leading this task and finish group looking at measuring success of local programmes. And following that true QI model, the focus has very much been on the discovery phase so far and understanding the current picture. Early thinking is going to be shared this afternoon at our NQICAN business meeting prior to being shared more widely throughout the clinical audit and QI members via the regional meetings and the forum. Then the intention will be to sense check the current thinking and to co-develop actions to spread current and new good practice at scale. If you are interested in supporting this agenda, please do contact Kerry directly, and we'll pop Kerry's contacts into the chat for you. And also you can drop us an email at the nqi.can1@nhs.net email, and Kerry will get back in contact with you. So if we move to the next slide then, the third task and finish group that's been led by Carl Walker, one of our other co-opted members, is very much looking at the forum, the website, the infographics, user network. Carl's been working with Sonia quite closely, changing the format of the monthly forum newsletter and also looking at some of the content that's on the forum itself. We are reducing some of the national clinical audit information to align with the NHS Futures platform to avoid that duplication. We've archived themed libraries for old posts as well. We're continuing to push information out to you via the @NQICAN Twitter account as well. Website we're currently looking at to review the information's up to date, but please do feedback to us if you think we can improve it at all to make accessing information easier for you all. Guest blogs, they're always welcome, so if you feel that you want to write one, then please do get in contact with us. Infographic Users Network, we're looking to run a 4th session in the autumn, date to be confirmed. If you've got any good case studies or examples of how you've effectively used infographics in your organisations, then please do get in contact with us. We can include you in future events, and we are encouraging you to share your information with our colleagues via the forum as well. There's a dedicated section for infographics. So if we move to the next slide then. Our regional networks have also been very busy over the last year reviewing their open model for NQICAN quarterly meetings and focusing their regional network meetings to align with this new model. Meeting dates and work plans are now aligned with this central meeting so that you can all then network and share and learn together on how this information impacts or applies or can be taken forward locally, as we've already mentioned. Chairs are busy reviewing their membership. We've developed invitation flyers and we've nearly finalised a new members pack that we can share across our networks as well. Each network's going to be busy reviewing its terms of reference so that they align now with the governance arrangements, which I'm sure Marina will mention when she provides her update for you. And we've been working with the regional network chairs on their own development and also developing resources to help with succession planning. So if you're on the call, you're not yet a member of your network, please do email us and we'll put you in contact with your regional network chairs. They've also been looking at inviting new members to the networks as well. Provider organisations that are in or partner organisations that are within your integrated care system to make sure that we are taking forward those quality improvement plans across the systems, across the pathways to improve patient care and services. Particular emphasis on that core 20+5 and those health inequalities as well. So if we move on then, in the interests of time, because I know I'm sharing a lot of information with you. So a couple of events coming up. We've got the third webinar on taking action on National Clinical Audit. That's being held via Teams on the 19th of July, and Helen will touch on that as well. And of course, our next open quarterly meeting being held on Teams on the 20th of September. So on the next slide, you can see our pledges. These are our pledges that we've made to you through year. It's as part of the NHS Fab Changes initiatives, where we saw them change their process to year-long continuous change rather than that week in time. NQICAN have made these pledges. They are helping us to drive our forward plan and our improvement priorities, and a lot of work is going into supporting and shaping the central NQICAN and the regional networks, and it's not always visible all the time. We're trying to make a lot more of that work transparent to you all. So I'm going to hand over to you now, Marina, if that's okay, so that you can cover your slides around your role before we move to opportunity for questions, and then hand on to HQIT for their update.
Super, thanks Vicky. Yeah, just very brief kind of update from me on my activity over the last quarter. So for those who don't know me, my day job role is Nottingham City Care. I'm the clinical effectiveness lead, but I'm also the general secretary for NQICAN, so I support Vicky, and obviously the regional network chairs and co-opted members as well. So in terms of our reimbursements, our finances for 22-23, words out, our total reimbursements came to 24,010. So we did have an underspend in 22-23 because of a number of budget lines, such as things like the fact that we've continued to hold online events rather than online meetings, rather than having in-person meetings with travel costs, etc. Our 22-23 budget is 30,958, and as we go through in the quarters, obviously I'll provide an update on spending against that, as I do previously. Other activity in this quarter, so obviously I've done the quarter 4 declarations of interest, as we do for all of our NQICAN members, to capture any interests and potential conflicts of interest, and also any sponsorship, etc., as we go along. I've also been working on updating our NQICAN governance document. This was uploaded onto our website about a month ago now-ish. It's been there for a number of weeks anyway, so that is available. If anybody would like to have a look at it, it has been updated throughout to reflect things like the fact that we've moved towards these open meetings as well. And as Vicky's mentioned, obviously we've had lots of work on Clinical Audit Awareness Week 23, so been involved in the awards and also in terms of planning last week's lunch and learn sessions. In terms of activity coming up as well, just to make you aware, the NQICAN chair election is due for September. The expressions of interest are going to be requested in the next week, and once those are received, they will come through to regional network members through your chairs, so that you can have a say in terms of where your network votes on the expressions of interest that come through. So do keep a lookout for those. And then just finally from me, so obviously you've heard about a number of webinars that are happening. So obviously the NHS England one on looking at national clinical audits. There's webinars coming up on infographics and also on the medtechs as well. But we would also like to capture your ideas in terms of what you would like to see webinars on. So please do send us your ideas, put them on the forum, or do email them through to NQICAN in terms of if there are areas of interest that you would like to see. One potential idea that we've got mulling over at the moment is potentially something on record keeping audits. I've been contacted in the past by quite a number of organisations asking to share our approach of how we do record keeping audits. Not that I'm any kind of expert on it, but I think it's useful to for organisations to be able to share different approaches and get ideas and take what works for you. So that's one potential idea we've got for a webinar that would focus on local clinical audits as well, because we want to make sure that we are supporting that as well as the national. So please do send us your ideas on that. So yep, next slide please. So just to very briefly touch on these, one of my roles last week in particular was in terms of the evaluations of our lunch and learn events. So we will be making sure that all those evaluation results are shared. the Mentimeter, which is the way that we've done our evaluations this year, rather than doing a sort of a survey that goes out afterwards, has actually helped in terms of getting an improved response rate. We did have an average of about 120 people per day over the week, and looking at our response rate for evaluations, it was just shy of 40% of those that actually did participate in the evaluations, which is, you know, really positive compared to, you know, how we've done it in the past. So hopefully, yeah, hopefully that will give us some great results, and we'll be able to share those with you more fully in September. That's it from me. Thank you. Oh, we've got a hand up.
Lovely, thanks, Marina. Yeah, we've got a couple of minutes quickly for any questions there. So Jamila, you've got your hand up. You'll just need to unmute.
Sorry,
lovely.
that was an error. Sorry.
Oh, not at all, not a problem. I've noted you popped in the chat that your record keeping would be a good topic for a local event, so we'll get that organised, I think, Marina. Lovely. Has anybody got any other questions before we hand over to HQIP? I think you might just need to lower your hand, Jamila. Lovely, not seeing any other hands come up, so I think we'll hand over to HQIP if that's okay. We'll get your slides up for you. Lovely.
Hopefully Caroline is there. Is Caroline?
I am here. Yeah. Great. It's me to start, isn't it?
Yes.
Morning, everyone. Can everyone hear me? Yeah, sounds like it. Great. Morning, everyone. Very happy to be here. So a couple of us from HQIP are going to talk this morning. I'm Caroline, for those who don't know me. I'm one of the HQIP Associate Directors, and I'm your, let's say, link person for NQICAN from the NCPOP team, National Clinical Audit Patient Outcomes Programme. So very happy to take any questions, for you to contact me between meetings, take messaging back and forward from HQIP and communicate and find out information for you. So I'm going to present a couple of slides on our updates and then hand over to a couple of my colleagues. Could I have next slide, please? So hopefully people know who we are, but there's our regular slide about what we do and who we are. Of course, happy to take any questions as they come along. I probably don't need to read that out. This slide stands. Next slide, please. So procurement work. So as people may know, we all of our contracts are let openly. So we openly advertise and invite tenders to our various contracts. Typically, they're for 3 + 2 years. So a 5-year contract for our various projects, and anybody is welcome to put themselves forward. We advertise all opportunities on our websites, and there are ways, if anyone's interested, that you can sign up to receive alerts when they go live. So what we've got planned for the next few months is the Mental Health Clinical Outcome Review Programme will be recommissioned. It's coming up for the end of its time, planned for the summer, and a brand new audit. Can't give you an exact date, depending on funders, but the plan is in September time. The National Eating Disorders audit will be launched, so a brand new piece of work there, quite broad, as you'll imagine, the different areas of healthcare involved with that one. Recently awarded, we have recommissioned National Clinical Audit of Stroke, Falls and Fragility Fracture Audit Programme, and the National Child Mortality Database have all got new contracts for the next 3 + 2 years in the normal way. And they are all either started or about to start. Could I have the next slide, please? So recently we've published reports you've got there in front of you. National Vascular Registry Report, the Child Health Clinical Outcomes Review Programme, most recent report. This is a specific report on the transition from paediatric to adult services. So very interesting report, that one. The National Lung Cancer Audit, a State of the Nation report. We put all the links in the slides there so that you can find them at your leisure. I would just say about the lung cancer report, that's one, it's not the first, but it's one of the first in this new style report that we've been talking about. So quite a short report, 10 to 15 pages, and all the links and the data are available from that report. You can go into the project's own website to find out all the detailed information and all the information for each provider trust. But the headline report is hopefully shorter and more impactful and a briefer read for everybody. Next slide, please. That possibly my last slide. Let me have a little. Yes, I think I'm going to hand over to Kim. Thank you very much. Happy to take any questions, I should say.
Yes, so for those that don't know me, I'm Kim Rozelle. I'm the Head of Patient and Carer Engagement at HQIP. I think because historically I've been involved with NQICAN, so I work with Caroline as a liaison between NQICAN and HQIP. So with National Clinical Audit benchmarking, this platform continues to be updated in conjunction with CQC. And as always, we welcome feedback on the platform via the benchmarking at address. Since March, there has been updated the National Audit of Inpatient Falls, Fracture Liaison Service Database, and the Prostate Cancer Audit. The audit data is also available on the Model Health System portal. We're continuing to support the inclusion of more audits on this portal, and resources now in place within the Model Health System team to restart these uploads. Following consultation with NCAPOP audit providers and the CQC, the final draft of the revised NCAPOP outlier policy has been completed, and the HQIP team is planning to share this with NHS colleagues for comment in July. Just to say as well, Susan Gillespie, who is our lead for this work, is hoping to attend in September. So hopefully she'll be here in September and she can answer any questions you may have, and we'll give you more detail at that point. Okay, so my bit of an update in terms of patient and care engagement. Next slide, please. Thank you, Sonia. So as part of the National Obesity Audit, I think I've already updated that we are leading on the engagement part of this audit, and we have a user panel of diverse service users to produce supporting resources for patients and carers to help them use the audit information. So we've actually got a specific piece of work to get along with this year. With NCAPOP, as you've already heard, there's been no new commissioning, but there has been PPI as the new respiratory audit commences, and also in some of the contract extension work. In terms of our service user network, this quarter we engaged members of our Sun in the core judging panel. So in terms of the Audit Hero Awards, we had Sun members as part of all of the judging panels. And the next piece of work is our upcoming Richard Driscoll Memorial Award, which is annual awards for HQIP commissioned programmes to celebrate their patient and care engagement activity. So I'm going to be working at maybe looking at a bit of a research on that. So I'll be working with Sun members on that. And just as usual, our Sun, our service user network, is open. It's now open to anyone to join. So please encourage you all to share the link and get your patient and public community to sign up and hear about involvement opportunities in the world of quality improvement and clinical audit. Please continue to share examples of any activity you've got going on. You have my email address, and all available resources on how you can do that is on our website. So before I move on to Helen, just in other news, we updated you last time that our CEO, Jane Ingham, is retiring. So her last month will be July, but we have a new CEO in post starting in August. His name is Chris Gush. He comes from the Royal College of Veterinary Surgeons and has previous experience at the Department of Health and the Royal College of GPs. So more detail will be found in our update that will be posted on the forum. Thank you. So over to Helen. Helen's going to give an extended presentation about our quality accounts.
That's great. Thank you very much, Kim, and good morning, everybody. So yeah, my name's Helen Barron. I'm Project Manager for Quality Accounts and Subscriptions, and I'm going to continue with our standard updates, so looking at NCAPOP subscription activity, quality accounts list in the directory. And as Kim said, I also have a few additional slides this morning looking at an overview of the quality accounts list. So first of all, in terms of NCAPOP subscription funding, HQIP contacted trusts on the 4th of April requesting purchase orders for this financial year 23-24. And our latest progress update shows that we've got 68% of trusts having provided their purchase orders, and 39% of trusts having made payment already. A follow-up reminder was sent earlier this month, so earlier in June. And I suppose at this stage it's maybe worthwhile mentioning that if, as NQICAN members and clinical audit managers and coordinators, if you can help in any way and maybe follow up with relevant finance teams, then that would of course be very much appreciated. Probably worthwhile noting as well that for 22-23 financial year, we now have 100% of trusts having been invoiced. That's great, thank you. Can I have the next slide, please? That's great. So in terms of the quality accounts list, just a standard reminder that the list is available on the HQIP website on our quality accounts page, and that is alongside the list for 22-23 and some other information relating to quality accounts more generally. We're going to look in, as I've said, a little bit more detail at the quality accounts list in some slides that follow this update. And in particular, I'm going to kind of have a look at the process used to develop the list each year. Could I have the next slide, please? So in terms of the directory, again, just a standard note to say that the May version of the directory has been posted to the HQIP webpage and signposted as usual via the NQICAN forum. I'll continue to update the directory as needed, and just to let everybody know that there's a new version under prep for release at the beginning of July, so the beginning of next month. Okay, I'm ready for my next slide, please. So as I've said, just onto some more details regarding the quality accounts list. This is really designed to be a bit of an overview on the list, and in particular on the process used to develop the quality accounts list each year. Just to make the point, and I guess it's important to note that I'm talking about the current NHS England process, but this, of course, as always, is potentially subject to future change. So just an overview of what the list is. So a list of national audits, clinical outcome review programmes and other quality improvement projects that NHS England advises trusts to prioritise for participation and reporting. Worthwhile noting that the list includes HQIP Commission projects and NCAPOT projects, but alongside those that are operated by other organisations. The list is published usually in advance of each new financial year, and it supports the quality account, so the written report that trusts publish each year in June, I think. The NHS standard contract sets out the requirement to participate in any programme that's included in the quality accounts list. And just to note that HQIP facilitates and supports the development of the list each year. As I've already said, we've got a quality accounts page with some further information. Happy to move on to the next slide, please. Okay, so this is a little bit of an overview of the process and the timeline. Again, this is the current process. It's a NHS England process agreed with NHS England, and it kicks off each year with agreeing the principles and the timeline with NHSE. That usually happens late summer, so August, September time. In terms of the principles, included in those is the inclusion criteria, and I'll look at those in a little bit more detail on the next slide. The next step in the process is distributing the scoping survey, and this is a survey that's really designed to capture information that's relevant to the inclusion criteria. HQIP facilitate this scoping survey. We usually have a deadline around the end of September. We send out direct email invitations to the non-NCAPOT providers that are listed in the directory. The survey is usually managed through SurveyMonkey. There then is a review of the survey responses. that takes place in the autumn time, and those responses are then presented to NHS England for review and culminating in sign-off, and then we move through to preparing and publishing the quality accounts list, which we aim to do by mid-January each year. We publish that on the HQIP website, and we also signpost that through various HQIP communications and obviously through the NQICAN networking forum. I think I'm happy to move to the next slide, please. So now on to the quality accounts list criteria, which I mentioned before. So this is essentially 6 criteria, inclusion criteria, and we ask providers about these criteria as part of the scoping survey that I've just talked about. So all 6 criteria are set out on this slide. So the first is around coverage. So we ask if data is collected from at least 70% of eligible services nationally. Number 2 is about data being collected on individual patients. Number 3 is really looking at comparison of providers, so trusts, hospitals, networks, and we're asking what granularity of data will the project publish. Number 4, obviously, is there plans to actually recruit patients during the following financial year? Number 5 is about whether the programme reported on national clinical data within 12 months of the clinical activity. So it's sort of like a reporting window. And number 6 is asking, are outcomes and processes being audited against standards and guidelines and evidence? For example, NICE guidelines or recent research, etc. Okay, happy to move to the next one, please. So now I'm going to have a little look at the review of the survey submissions. So a summary report of the survey submissions is presented to NHS England. And this report looks at which projects and work streams could be considered for inclusion in the list, obviously based on whether the criteria has been met. And that is gathered from the information that's given and submitted as part of the scoping survey. There's also potential issues that need to be given some further consideration. For example, are there some new audits, new topics, new provider organisations that need to be looked at? The information is reviewed in November each year, and it culminates in sign-off and publication of the quality accounts list. I'm happy to move on, please. So I'm just giving a little bit of an overview of some sources, further information. HQIP obviously have our quality accounts webpage. There is also an NHS quality accounts page with some additional information and guidance, and it's worthwhile mentioning that Vicky gave a presentation, I think it was the last open forum, on quality accounts more generally. Okay, on to my final slide. So finally, we thought it might be helpful to look very briefly at the directory, so to think about what the directory is, what it isn't, and how it relates to the quality accounts list. So the directory is designed to be a tool or a resource. It's an Excel-based document and it's manually updated. It's for guidance and information only, and this is an important point. Data is provided by the project providers, usually at a fixed point in time. The directory requires manual updates, and so it is not necessarily up to date at any given point. And I suppose it's really designed to be a starting point to further investigation, maybe into specific questions or looking for more detailed information. The diagram that I've got on the slide is really, I suppose, to illustrate that whilst the directory includes NQICAN projects and also projects that are listed on the quality accounts list, there are other projects also included in the directory. So it cannot be used as a list of mandatory projects in any way. And of course, this probably goes without saying, but the directory includes some filters that can be used to maybe select projects or work streams that are included in the quality accounts list, both for this current year and the preceding year. I'd also like just to say that, you know, we welcome any feedback, any suggestions about the directory, how useful people find it or not useful, and any suggestions for changes. By all means, send those directly to me. My email address is there on the slide. I think that was my last slide. So, yep, we're, of course, happy to take any questions. Thank you very much.
Lovely, thank you, Caroline, Kim and Helen. I can see we've got a question in the chat straight away from Zoe Lowe, one of our co-chairs from the Yorkshire and Humber Network. So with the new eating disorder national clinical audit and the new national audits for cancer under NQICAN, how many new national audits do HQIP anticipate adding to NACPOP over the next 2 years? And is there any consideration for audits to be removed?
Shall I take that one? Can you hear me?
Yes, Karen, go for it.
Oh, good. I couldn't see any nods. Feel free to take down the slides if you wish to, so I can see more people about it, but I don't mind. Yeah, thank you. Good question. Hi, Zoe. Well, the first thing I should say is that it's NHS England and the Welsh Government, the funders, that make that kind of decision, so they might want to comment after me, so please do. I don't know if the question's coming about resourcing, so perhaps it's helpful to say the eating disorder. So every time an audit comes up for renewal, there's a group called the Executive Quality Group, the Clinical Audit Subgroup, made up of NHS England, NQICAN attends, and HQIP obviously, and various other bodies, and they would decide on its relevance and how useful it is and whether it will be recommissioned, and any new audits go through that programme. So there's a process around that. And eating disorders, for a start, I should have said, is a mental health audit, so I don't think it will affect everybody in this meeting. Possibly, potentially in the future, it might expand outwards, but at the moment the focus is on mental health beds. So what else did I want to say? Yes, I suppose through that process, the national clinical directors and others look at what reassurances and assurances looked for, how the audit programme fits in with other quality improvement programmes that are being commissioned, and there's also been this move. I don't know if the question's coming from a point of resourcing, but there's this move towards collecting routine data. There's only 1 or 2 audits now that collect bespoke data. The other audits, including most of the work that's going into the new NQICAN, the National Cancer Audit Centre, is collected from that comes from that routinely collected data that's already collected. So please do expand on the question if you wish, and NHS England might want to say more about the process.
No, we've not got no takers from NHS England chipping in. Thanks, Caroline. Jordan, our North East Clinical Audit Network Chair, has just popped in the chat, replying to the May update of the directory, Helen, but probably saying he could have probably emailed you, but will the July update reflect the change of NASAP to NRAP for the asthma COPD audits?
Yep, sorry, I just posted a reply. Sorry to have missed the post on the forum, but yeah, I'll follow up with that. Thank you.
Lovely, thank you. Okay, not seeing any hands or any more questions in the chat, so I think we'll thank you so much, HQIP, and we'll hand over to Helen from the transformation team for the NHS England update.
Thanks, Vicky. I'll just wait for the slides coming through. So hello everybody, I'm Helen, I'm the Knowledge Management Lead at NHS England, and I've been involved in this Taking Action learning community on national clinical audit. So what I'm going to do today is just reflect back a little around what I shared with you a few months ago, I think now, take you through some of the learning that's taking place through the various webinars that we've been holding, share with you the futures site that we have, and really take any questions, and really keen to understand from you all what is most useful for you as we progress this work. So on the next slide, that just relays what I'm going to talk to you about. I'll go through the shared purpose, what we did around service design, a bit about the community and the learning from those webinars that we've been holding. I am in an open plan office, so I hope you can all hear me okay. Just let me know if not. Makes a difference from being at home. So this work actually stems from the NHS England Executive Quality Clinical Audit subgroup, who asked for this work to be taken forward. And so we have a design group that meets regularly. In fact, our next meeting is this afternoon. And originally we had this shared purpose. So this is very much in collaboration, this work with NQICAN, HQIP, NHS England, Royal Colleges. The original premise that we had was to create a learning community, particularly around to support people taking action on national clinical audits and signpost to those great resources that are already out there. And what we've done subsequently is we've created a logic model as well that sort of sets out what we're trying to do. So on the next slide, this is you'll see that we've got this narrative view, which really describes what we're trying to do. I won't attempt to try and read all this out, but it is on our Futures platform, and I hope this resonates with you all. Very happy to take any feedback, or if you want to take it away and add to it, or let me know if you've got any further suggestions, because I think there is definitely something about the taking action community to make sure that we are evolving, but also make sure that we are developing something that actually makes sense to everybody. So what we're trying to do really is to take action, particularly on outcomes, grow this learning community so people can access expertise, insights, and also ensure that we are putting things in place where people can learn together, which will mean in the end that we've transferred that learning into practice. So happy to take some any feedback around that, so we can evolve this logic model narrative. On the next slide, you'll see that the work that we've done really stems from user research. That's what we spent quite a bit of time doing. So many of you I know got involved in this, and this is just a reminder that we really wanted to understand what our users need. We know that people said that they value having a place to share how to take action on national clinical audit, and also that our learning community is really for both people who are really involved in clinical audit, but also wider than that. So this is, I think, an aspiration that we have to also make sure that we are reaching out to other people who might not be as closely involved, but absolutely need to understand and help influence and bring about change. So on the next slide, we also have, I think, the original premise that we had. Oh, here, okay, this, yeah, sorry, I must have taken out one slide. This side is what we've been progressing with actually since I last spoke to you. So we've held 2 webinars. The first one was in May, which launched the Taking Action community. I know many of you joined. We had a great turnout, so we had about 300 people who joined, and about more than that who registered as well. So we generated about 250 insights from that session, and we've now got, I think, nearly about 260 people actually on our Future NHS community, with over 4,000 views, and that continues to grow. So we had some emerging themes that came out of the first webinar. These should all resonate with you. I don't think there'll be many surprises, but there was definitely some learning about how people are making decisions around progressing with recommendations from national clinical audits. We heard about how people are interpreting those findings, particularly around smart actions and so on. We heard from Mark, who's from GIRF, one of the GIRF leads around triangulating data. And one of the themes that came up from that first session was around the culture change required, and we followed that up on our second webinar. Resourcing and time came up as well. So we heard some examples, I think, around how that's what people have put in place, I think particularly in Somerset, which I'm aiming to follow up and write up some of those examples. So that's what we found out at the first webinar. And then on the next webinar, you'll see a bit of a summary around what we found on the second webinar. We had 150 people joining. This was during Clinical Audit Awareness Week. I think because of the time, it was 3 till 4. So that meant I think we had slightly less people joining. But we did have Vinder Wacker join, as Vicky's also set out earlier. So he spoke very eloquently about NHS impacts. So I think this shows the value of the Taking Action community, because it means that we're trying to join the dots and help ensure that you all have an early sight of some of the emerging work that's coming out. So I think NHS impacts is potentially a real enabler for how you can all take action on clinical audit. So the premise really is around, across all organisations and systems, to have a continuous quality improvement approach really embedded from board down to ward level, and that's there are 5 components which you can have a look at, which is on the NHS Impact website, which sets out the premise. And I think what this is helping us all to do is to see what is possible in terms of the future direction around culture change. So Vin's presentation, we also heard from Michael Sykes as well, who was sharing some really interesting work that he's been involved with around change. Both of those presentations are on our Futures site, so you can listen back to them if you need to. We also, on the second webinar, had lots of examples and learning that we're going to follow up. So if you were any of those people listed, we will be contacting you to just share your work through our Futures site. And we've got a few questions that we're also going to answer at our meeting this afternoon to make sure we've got those answers. On the next slide, you can see just another preview around our learning community, which is hosted on Future NHS. So if you haven't joined, please do so. I'll put some links into the chat. I hope that everybody's finding it easy to navigate if you are on there. We can provide support if you need it, if you haven't used Futures before. We urge everybody to make sure you've got an updated profile on there, that you introduce yourself on the forum, and that you keep thinking in your day-to-day work, what can I share through this platform around helping people to take action? Have I got any improvement plans that I can share, for example? That's the place where you can do it. On the next slide, these are just some screen grabs, which go through what you can see on Futures. So we have got this discussion forum going. We've got some topics that are on there. So there is a potential piece of work that is actually being developed at the moment by Carl and Vicky around looking at a particular national clinical audit to see how we can use the community to bring about change. We've still got an outstanding question around the epilepsy 12 data collection. I posted a question around AI and machine learning. I don't think anybody's responded to it yet, but if anybody's got any thoughts, insights, learning, questions around AI and machine learning, then do post there. We've also signposted to Model Health System and answered some questions that came up at the first webinar around the data opt-out guidance. And on the next slide, this is a few more screen grabs which show you what Futures look like. This area is in development, really. We're still trying to write up some of those examples, which will be on there shortly. And we've also got on the next slide a section which aims to help with signposting, particularly around national clinical audit. I know there's a lot already out there, so this isn't aimed to duplicate, but we're continuing to work with audit providers to make sure that we can see those really useful resources that will be easy to find on there, and happy to have a further discussion around that if anybody will find that useful. And so I think the next slide just takes us to the other sections that we have. So we put all the webinars that we've been holding, all the slides, a summary, and the recording are on the events section. You do need to click on a purple tab when you get to that events page to see those recordings. And we've also got the about section that has a logic model, has more info about the Taking Action community, and we've got a communications toolkit as well. So what would be great is if you could share the Taking Action community with your colleagues, in particular people who are not as immersed in clinical audit as well, so that they can get involved. And on the next slide, we have, just a reminder, when you do get to the site, make sure you click join, so that makes sure that we know that people can access all the content, and it also helps our numbers as well. On the next slide, we have, I think, a reminder about the next webinar. So again, I put this link in the chat. So the next one's on the 19th of July, 12 to 1. We're just preparing this afternoon to firm up the speakers. I think we're hoping to have a speaker around leadership, but we also have some specific examples about how people have been taking action as well, and there'll be an opportunity for a group discussion. What we've been learning as well as we've been doing these webinars, the first one we had lots of breakouts. The last webinar we had a discussion with everybody on the call, and that seemed to work quite well. So we're continuing to sort of evolve the webinars as we go along. And I think that was the next slide is just the final slide, I think, which is just a plea to get involved, but also, if you want a conversation, if you're thinking, oh, this isn't, there's something else that would be useful, or I've got something to share, just drop me a line. I'm happy to have a conversation with you. And that's the end of my presentation. Thank you.
Thanks, Helen. That was a fantastic update and really good to see the outputs as well. So yeah, we've got a couple of minutes, I think, before we hand over to John, if we've got any questions. Thank you to everybody that's responding to comments that are coming through on the chat. That's brilliant. We've got a few links shared there as well. Not seeing any hands at the moment, and I don't think I've missed any questions in the chat that hasn't had a response put in. No, it doesn't look like it. So thank you so much, Helen. Really valuable information. And we'll hand over to John now, if that's okay.
Yes, thank you very much. Great to be with you. So I'm John Ford. I'm a senior clinical lecturer in health equity at Queen Mary. So I'm an academic public health doctor. And I work mostly doing research within Queen Mary, and I lead a program of research around health inequalities. I'm also a consultant in public health at NHS England. So this morning we're just going to share a research study which is just kicking off, and we're going to tag team this between myself and Lucy. Lucy, do you want to just introduce yourself? Can't hear you. Well, I can't hear you. I'll give you a minute, and you can try and come back in. So I'll maybe start the presentation, and then we'll go from there. I'll just share my screen. Okay, so I'm going to talk about this research study which we've just started. It's a £1.3 million NIHR funded study, which is running over 5 years. It started about 6 or 7 months ago, and we're just getting going. So the background to it, we know that there's about 2 million reports of poor quality care reported by staff in NHS hospitals every year. And previous research has estimated that there's about 11,000 deaths in hospitals due to poor quality care in England alone. And obviously this is why we're here trying to drive forward the quality improvement programme. And obviously there's hundreds, if not thousands, of these programmes that happen every year across the NHS at different levels. One of the big questions we don't know is who benefits most from quality improvement. So what's the distribution of benefits across different groups? We've got some cautionary examples of QI programmes which have actually inadvertently increased inequalities. So most of those examples come from the US, but to give you a few examples, so in New York they introduced a mortality scorecard for surgeons. The idea being that if they published surgeons' mortality scores, then that would help drive up care. And actually what happened was it led to surgeons cherry picking patients and led to an increase in racial inequalities, which took about 9 years to resolve. We also know from a UK example that the continuous glucose monitoring in children has been introduced and has tended to benefit more affluent groups and has had better outcomes for more affluent groups. So we've got some examples of QI projects which have increased inequalities. We also know that QI projects can address inequalities. So whether they're targeted schemes, so for example, quality improvements focused on trying to improve care for homeless populations or for drug and alcohol teams within hospitals, or I guess universal QI programs which take an equity perspective, so they maybe think about cultural aspects to how they improve quality. So that's the background. So the research questions we've got are two. One's what are the characteristics of QI approaches in NHS hospitals that increase or decrease inequalities? And we don't want to just look at this in a binary way, but we want to think about, well, who does it benefit most, in what circumstances, how and why, to try and understand the context. And then secondly, you know, how do we support practitioners, hospitals, organisations to do more equity-focused quality improvement? We're not trying to reinvent the wheel here. We're not trying to come up with a new model, but you know, how do we support what's already happening in hospitals to make it more equitable? So we've got 5 phases, roughly over 5 years. So first phase that we're starting at with just now is literature review. I'm hoping that Lucy will be able to talk a bit about that. In the autumn, we'll move on to staff interviews. So we're looking to interview people involved in QI, and this is maybe where we'll be trying to reach out to NQI community. Phase 3 is hospital studies or hospital case studies. So we're going into a selection of 4 or 5 hospitals to look at how they do QI, good and bad examples of QI projects which may impact on health inequalities. And the idea is to try and combine all that information together, and then think about how can we co-produce some support for hospitals and staff to think more about equity within QI, and then roll that out and do some evaluation. So that's roughly the plan and the research. As I say, it's roughly split into 5.5 years. So at the minute we're doing the review and the interviews. So we're going to see, Lucy, how's your audio doing? Are you able to come back in? No, I don't think so. Okay, go to plan B. So I'll take you through the slides. No, I'm afraid. Right on. Okay, so in terms of so we've started the realist review. So a realist review is a type of literature review, but unlike traditional reviews which try and come to a judgment of does something work, yes or no, realist reviews try to understand, well, you know, it might work in one context but not another. It might work in a busy inner city urban hospital but won't work in a rural hospital. So we had to try and unpick some of these contextual factors. And so we're doing this, we started the review probably 3 or 4 months ago. It's a kind of fairly standard process in terms of research. So I need to try and look at all QI studies which have been published, and to look at how they've affected inequalities or not. And we've got inclusion and exclusion criteria, so we're just looking at QI studies which have in some way reported on health inequalities or disparities. We're looking at 2 different ways. So either we're looking at both the kind of gap, so the differences between socioeconomic group or ethnicity, but also targeted studies or targeted QI projects. So that might be studies which just focus on a disadvantaged group. So we're looking at both of those angles. Lucy spent a lot of time looking through about 6,233 papers, and we've narrowed it down to about 22 gap papers. So they look at the gap between 2 groups, and then 16 targeted QI papers. And we're using this software called RIAN to go through that. In terms of where we've got to so far, so we've found those 30 or 40 papers, and we're going through the process of reading through them, screening them, and coming up with some reflections or some emerging theory. And these are some reflections which we've pulled out. First of all, most of the papers that we've found looking at inequalities in QI are arising from the US. We're not quite sure why that might be, so any thoughts would be welcome. A lot of the QI, equity-focused QI stuff from the US is actually focused on anti-racist training, so it tends to take more of a racial inequalities angle. Again, it'd be interesting to explore to what extent that happens in the UK, and especially QI programs in the UK. The lack of equity-focused training data doesn't seem to be an issue which is coming up. That's something we thought might be an issue, but actually in the literature, the lack of training or data doesn't seem to be a big issue. Data seems to be driven by QI. Data-driven QI seems to be central to equity. So again, trying to disaggregate the data is key to the studies which we've found, which are useful. We've started developing some of these specific context mechanism outcome frameworks, so CMOCs, which you can see on the right-hand side. And so that example on the right-hand side says, you know, in the context of a culturally appropriate care, or in the context of anti-racist training, then that leads to an increase in patient trust and staff knowledge and awareness, which then leads to more equity-focused QI. Okay, so those are some initial reflections. Any thoughts on that would be welcome, and we can talk about that in discussion. And just to mention the interviews, so come the autumn, we'll be kicking off some realist interviews. So the idea is to use the information we pull out from the literature and take that into interviews. We're very conscious that the literature is only one chunk of information, primarily from the US. We want to go and hear what people have to say. So the idea is to take some of the information we generate from the literature and go and ask people what they think of it, and hopefully improve it. And so you can see the aim there, that we really want to explore factors and knowledge around equity-focused quality improvement with staff. It's kind of interviews are undertaken in this cyclical teacher-learner process. So we share some theory, and we hear back from staff what they think about the theory, and hopefully that process refines it. We're trying to get a whole mix of people, both from senior leadership to clinical leads, QI leads, project leads, and we're hoping to recruit both from Q community, but also we're hoping that we'll be able to build something with NQICAN to recruit some staff as well, and undertake about 20 to 30 interviews. So as I say, the whole idea is we start in autumn, and we'll be doing interviews early 2024. I would be interested if people are interested in or want to contribute to any of that. So I'll stop there. I'm not sure if Lucy has come back or not. I don't think so.
Can you hear me at all now?
Yes, yes.
I just
perfect.
had to leave and rejoin. That's yeah.
That's okay. Lucy, I don't know how much you caught of that. Do you want to add anything else?
So I think what I've found from going through the papers so far, as John mentioned, is there is a really, really strong sort of US bias with the papers. So with the GAP papers, for example, I think all but 2 are US based. So this is something that we're thinking about, and I was hoping that we could get some feedback as to what you think about this. But from another steering group we've had, one of the things that we got feedback on was that QI projects in the UK sort of don't get published. So in the US, there's a really big impetus to publish as part of your medical training, but here there just isn't the time or resources. So we were wondering what you thought about that, and just sort of general feedback on the project, because one of the things we're really keen on is getting input at all stages throughout the review.
Okay, thanks John, and thanks Lucy. So have we got anybody that wants to raise their hand to respond to John and Lucy? Lovely. Layla.
Hello, everyone. I just wanted to say that I noticed that your programme span of 5 years, and there is a huge amount of health inequalities work going on in trusts. So I do suspect that between now and year 4, you are going to see a very different picture because this is such a fast moving landscape. So trusts and sectors are talking about how they're going to address health inequalities and look at all this information. So I think it's really timely, your work, and really brilliant. But I do suspect by year 4, 3, 4, the landscape will have shifted very, very fast. Thank you.
Yes, I agree. And actually, what we're particularly keen to do is try and build the evidence base so that actually the changes we see now are long term rather than a kind of flash in the pan. So we're hoping that this provides evidence for that long term change.
That'd be brilliant.
Lovely, thanks Layla. And Layla's our London Quality Improvement and Clinical Audit Network Chair. Okay, Carl.
Yeah, no, thank you for the presentation, and you know, it looks a very good project, that one that we can all support, I'm sure, on this group, and look forward to seeing the outcomes. In terms of publication, I mean, you might have to open up your criteria because there is a lot of sharing in QI, and there's a lot of networks and forums that people share their published QIs, not through published journals, for instance, but they might be or the NHS Futures is got lots for interest in, you know, for example, and you know, like we have clinical audits. I mean, if you, a lot of people sometimes don't classify clinical audit as quality improvement, but we certainly do here within NQICAN. And that's worth factoring in as well, I suppose, into what's your entrance criteria into the projects, because over in the States, audit is for assurance and not necessarily for improvement.
Yeah, thanks, Carl. That's a really great point. And we do plan to do a kind of grey literature search. I'm slightly worried that even with that, you know, when we look, for example, doing a Google search for QI projects, we're not going to find much out there. So if there's other resources or databases you can suggest, we'd be delighted to hear about them.
I mean, our librarian at the hospital sends me a list of all the publications that are relevant for QI and what we've done in Leicester, and there's lots, so I can patch you into her search criteria that they use within the library. That'll probably be helpful.
Yes, please.
Brilliant, thanks, Carl. I think we've got a few comments in the chat as well. I think Sarah's just said shared the square guidance is really helpful, but people do need to think about publishing as they're planning their project as well. Thanks. Lucy's shared the link to find out more about the project, and Kerry's also said as well, yeah, COVID has exposed health inequalities over the past 3 years, so we might see that literature growing. So Sarah, you've got your hand up for a question. Sarah's currently our Mersey Quality Improvement and Clinical Audit Network Chair.
I think it was just to say that, you know, historically, for the junior doctors and for medical trainees, their publications would have been around clinical audit, not earmarked as QI projects. That's what they had to get as for their portfolio. But that is changing now, and it's, you know, it is wider. So there's something about, you know, sort of seeing what the requirements are around those portfolios and how that is evidenced. You know, that might be another source for you to tap into.
Yeah, that's a great thought.
Thanks, Sarah. Helen Althwaite's just popped in, John, as well into chat. Happy to have a chat with yourself and Lucy as well around some of the NHS impact work and the futures sites and navigating. So, and Helen's contacts in the chat as well already. And thanks, Jordan. Jordan's shared the Fab NHS Stuff monthly QI evidence updates as well, because they're really helpful for publications as well. Thank you, everyone. So yeah, worth going over to the link that Lucy shared around the project as well. And then John, obviously we look forward to hearing more coming out from the project of how you want to engage with us going forward.
Yeah, great. That'd be lovely to come back and present some results at some point as well.
Yeah, no, that would be great. Yes, we'll keep in touch. Thank you. That's brilliant. Okay, right, we'll hand over to Chris Connell now from NICE. Are you there, Chris? We've got you.
I'm there.
Oh,
I'm
lovely.
there. Yeah. Thank you very much for inviting me back. I think myself and Joe from the field team were here last September, and I know there's been a few regional presentations and things that have gone on and attendances at your meetings as well. Apologies to Sonia as well, a big apology, because I think there's been angst over the NICE security protocols and actually sending a presentation through. And to add to that, I'm unexpectedly at a kind of clinic this morning, so I'm in a car park with my son. So I'm on the 4G, so I hope it all works. So I may turn my camera on. I'm surprised how smooth it seems actually. But so what I'm proposing to do, if it's okay with everybody, is I'll run the slides from my end, fingers crossed, and then I'll negotiate the fearsome NICE security to actually send a presentation through to Sonia to distribute afterwards. I think, to be fair to NICE, we're moving to SharePoint, and they're trying, on a sustainability point of view, to reduce the size of PowerPoints that are being sent. But maybe they've reduced it a little bit too much. So on this particular occasion, so we'll see how we go. But here's the kind of moment of truth coming. I'm going to share some slides, and I'll just run through in a moment. So bear with me. Cool. Here's the question. Can people see the slides?
We can, John. I mean, sorry, Chris.
That's okay. John's my middle name. That's fine. So that's great. Okay, then. I'll talk for about kind of 10 minutes or so, and then happy to take questions. I'll take them at the end if I may, because I can't see anybody at the moment. So hopefully it'll work. There's a lot of change going on at NICE, even since last September. I don't think I've probably got time to cover absolutely everything, but I thought I'd just try and focus on areas of priority for NICE at the moment. A little bit about the whole issue about productivity, whether you want to call that affordability or efficiency, health inequalities, new guidance, early value assessment, and an update on what's going on there. A little bit about real world evidence framework and shared learning. So hopefully that'll be of interest to you. I guess the one thing to kind of be aware of at the moment is, as NICE is changing, as the world and healthcare and social care is changing, we're trying to kind of reprioritize and refocus a little bit what we look at. You'll spot the deliberate mistake there that we're transforming in 4 ways, and we've got 3 boxes. The 4th one I took off the bottom, which is about internal change within NICE, which is probably not particularly of interest to you at the moment. But we produce a lot of stuff, as people on this network or network of networks really know about. Sometimes you could argue, do we produce too much stuff, and it's difficult for people to focus. So we are trying to have a bit more priority on focusing on what we think matters most to people such as yourselves and the wider health and care system. And we've taken a lot of feedback on that, trying to make sure that our guidance is relevant given the pressures that we're all working for. Again, our guidance is pretty comprehensive. Is it too comprehensive sometimes? Is it timely? Is it easy to use for NHS and care staff? Sometimes it is, sometimes perhaps not so much. So what might we be able to do about that to try and improve what we do? And can we make more use? We have a lot of data within NICE about our guidance. We have some data, some information on implementation, quality improvement. With the previous speaker, how can we do more with the information that we've got to make sure that we've got a good feedback loop with people such as yourselves, so that the topics that we're focusing on are really what's wanted, the format is what's wanted, and we've got evidence of impact about what we do. So those are the kind of 3 kind of key areas that we are focusing on at the moment. And if I go to the kind of first box, this just gives you just a little bit of a a flavour of examples, if you want, about what we've been doing over the last year. People are kind of familiar with COVID therapeutics, I'm sure, but there's a lot of work going on within NICE to try to produce guidance and try to pin down the evidence base on virtual wards. There's obviously a real drive from NHSE within ICBs and ICSs about them as well. But what is the evidence about what is best practice, what's going to work, what's going to make a difference, what is going to help patients and make a good use of really scarce resources. The digital world, and I'll come back to this, is exploding. Mental health seems a particular area of interest within the system. So we've produced the first, via the Health Tech Evaluation Guidance Programme, which I'll come on to, guidance on mental health apps. Resources on health inequalities and productivity, and I'll talk a little bit more about that. I won't go on to this any more details, but just to draw people's attentions about NICE's antimicrobial guidance. We've produced guidelines on antimicrobial resistance, and one of the reasons for that is obviously the fact that we're not producing new antimicrobial products as a country or as even internationally. NICE has kind of really led the world on the first guidance on new antimicrobial drugs. And one of the reasons why we're not producing that internationally is that it's not, excuse me for a moment, the financial model doesn't work. It's currently based on remuneration for the maximum number of usage, if you will, or number of prescriptions, and that is not what we want in antimicrobials. We want the less use, the better. So we've come up with what you might call a Netflix subscription model. So we're actually paying companies to produce a product that we actually don't want to use unless we really have to fight the resistance. So that's something that's a lot of interest in that internationally. And the medtech space is growing all the time. And I think it's fair to say that NICE's ambition is to try to respond to that on behalf of the NHS. And our medtech programme is likely over the next year or two to become as prominent and as important and as have a much kind of volume behind it as our health technology health technology programs, our drug programs. So that gives you a little bit of a flavour of where we're focusing on, but looking at focusing on that a little bit more on the inequalities and productivity. I hope just we published in the last few weeks, I don't know if people have seen this, a new resource on, and you can see the link below, recognising the pressure that the health and care service is under. So we've gone through our guidance and we've tried to pull together relevance guidance, and particularly where we can go down to recommendations and bring those into one place, aligned to current NHS priorities, the operational planning guidance produced by NHSE, and also going back a little bit, the NHS long-term plan. It's hopefully easy for people such as yourselves to access. I'm guessing that some of you will be tasked with trying to try to look and support ways which services can kind of make the most of scarce resources, and this might be something that you might want to take a look at. So it's looking at efficiency and effectiveness, and it's based on the best available evidence. You may well have implemented many of these recommendations, in which case that will give you some assurance that about what you're doing, but there may be some new opportunities that you want to take a look at as well. We wouldn't want to oversell this. It's not going to save the any particular health economy from financial position that they're in, if they're the challenges that people are facing, but we think it can help, and we think it's a relatively straightforward thing for people to do. So you get a bit of a flavour if you look at it there. We've got recommendations on workforce, which I think are at guidance recommendation level, guidance level, but we've got others on mental health, learning disabilities, maternity, where we actually go down to individual recommendations that you might want to take a look at. So hopefully that might be of help to you. We're really interested to hear from people as to whether this is of good value? Do people want more of this kind of thing from NICE? So we'd really love to hear from you if you, as and when you and your networks take a look at it. Since I was last here with Joe in September, I think we mentioned health inequalities. You may have looked at this page. We've produced a dedicated page, the same principle as productivity, trying to bring as much as we can that NICE has got to say about health inequalities into one space. So we've mapped everything that NICE has got against the Core 20+5 programme. And I think it's in the last week or so, we also published, we've also mapped our guidance against the Core 20+5 for children and young people as well. So we hope, again, it's a shortcut to finding recommendations, not just guidelines, that might feed into your system or your place-based or your trust-placed programs on inequalities. Core 20 is the key focus, but we've also recognised, particularly with people working with local government, where the frameworks such as Marmot and Labont are kind of more widely used. So we've aligned the guidance to those as well. We want to develop this, we want to build this with case studies, and I'll come on to case studies again shortly. So that's something else you may find useful. The couple of things that you might want, I'm going to focus on patient access to devices and apps, but just to bring you up to date briefly, some of you that may be involved in HTAs might notice that there are more and more of those coming out from NICE. I think last year we produced more guidance on that area than we ever have before. And the aim has been to increase our capacity by around 20%. That is responding, if you will, to the market. There are more and more drugs that are going through MHRA that are finding that are getting approval. Those drugs will find their way into local systems one way or another. And we feel it's important that NICE covers as many of those new drugs and new recommendations for new conditions as possible, so we continue to provide a signpost to people such as yourselves as to whether these drugs are effective and cost effective. So you will see more of these coming out. There are issues around affordability as more guidance comes out from NICE, and I don't think we have all the answers to that at the moment. We're continuing to look at what's called digital living guidelines. I think we mentioned these last time, which is trying to keep our priority guidelines up to date. We've had a lot of feedback from people such as yourselves and clinicians about, well, how up to date do you mean? Because some of the COVID stuff that we've updated, people have said that's too fast, that's too frequent, we can't keep up. So we're trying to find the sweet spot where our guidance is cognizant of new evidence, particularly significant new evidence, is updated frequently, but not so frequently that people can't keep up with what we're doing. So we're still working on that. Looking at women's health at the moment, we haven't got a time at the moment when this will be the first ones will be coming out, but just keep your eyes peeled. What we are working on at the moment on the right hand side is medtech, particularly digital, and we have a new type of guidance. And there's a bit of an anomaly here because on the one hand, we're trying to bring our different guidance types together via the digital living guideline. And on the other hand, we've produced a new guidance type, which is called HTE, Health Technology Evaluation. You'll also hear the phrase EVA, Early Value Assessment, but that is really the process. And we have started to produce guidance under the acronym HTE. There's lots of questions, and this is a guidance program that's producing guidance when it's still under design, if you will, about what we should be doing here. What we're trying to respond to, along with HTA, along with NHSE and others, is the exploding medtech digital AI market, which is almost chaotic in some areas. How do we provide signals to the NHS about what is a promising technology. How do we get that technology into the NHS? How do we get it used in either current care pathways or new care pathways? And how do we build the evidence base when the evidence base is really, really limited at the moment? So we're really working with industry. We're trying to highlight what the priorities are. We're trying to horizon scan about what we think are promising technologies. And we're looking, as part of the HDE process, to do quick assessments of those promising technologies and actually make provisional recommendations. So we've done about 7 or 8 of these at the moment, and there's an example here on digital mental health tech for children and young people, and that was the first one. We've done about 7 of those beyond that. So industry is starting to get to an industry that's probably had, in some ways, kind of quite minimal regulation, quite minimal kind of assurance about what it is they should the NHS be using their products, is starting to begin to get used to NICE and other bodies actually saying, hold on a minute, how does this fit with these priorities? What is the evidence that you're using? But there's a lot of questions that we're still grappling with. So the EVA that you'll hear is publishing as health technology evaluations. The methods that we use are different to what we use in other guidance programs. I said we've now got 6 HDE products. Since this slide came out, we've got 8, and that will grow. And you'll see the forthcoming topics on that link. We're working to kind of put more information out there about what this means. There are things called evidence collection frameworks that we're looking to develop. So we're trying to work with NIHR about how do we get more information when we make interim recommendations on this program. What happens if that evidence doesn't support the initial recommendations from NICE, that something is not as good as we first thought? So there's lots of questions that are still out there that we're trying to work. So this is very much guidance kind of coming out while we're still designing the program, which is not something that we've done before. So it's a complex area. And just to draw your attention as well to if people haven't used this, this is the real world evidence framework that has been out from NICE for probably about a year. I don't know if people have used it themselves, but NICE is starting to use this, and it was really a response to some of the things about medtech. But you'll find the link there may be of interest to yourselves. And I was interested to listen to the previous speaker looking for evidence on quality improvement. But this framework can be used if you're working with partners, trying to define what definitions of real world evidence, how it might be used, and how it might be incorporated into our guidance. But it's there on the website for other people to use it in the planning, conducting of their own evidence studies as well. So if people are involved in research or looking to audit research, it might be something that you want to take a look at as well. And lastly, coming back to the very local, is case studies. People may be aware that when I was here in September, we had suspended the NICE shared learning collection. We weren't taking any more examples, and we've looked at that again, that whole collection, whilst that's still available and we're not taking new examples at the moment. We will be. We've done a few via our comms colleagues to put on the website. This is a really good it's a social work case study, but it's really about the interface between social work and the NHS in many ways. So if you look on features, you'll see a few international examples which may or may not be relevant. You'll see 1 or 2 NHS examples, but the ambition is to bring back the shared learning later this year. So if you do have examples, do keep them to hand. And later in the year, we will be back and looking to publish a lot more of those, probably in a slightly different format from the old shared learning collection, trying to make the case studies perhaps a little bit more usable for people such as yourselves. So I'll stop there. I hope that's been of that recap of what we're doing at the moment is of some interest, and if there are any questions, I'm happy to take them.
That's brilliant. Thank you, Chris. That was really timely update for a lot of us, I think, working with NICE in our organisations. So Sarah's just popped quick question in the chat. Do the Core 20+5 aligned NICE guidance link in with the Innovation for Healthcare Inequalities programme?
Wow, I don't know. Is the answer to that? But I can come back to you on that. I know we spent my colleague Deb O'Callaghan, who's somebody some of you will know, is the lead, and I'll speak to Deb. I know she spent a lot of time speaking to a lot of people, and I know she was involved in HIP. But I'm not clear on the outcome, so I will come back to. Is that looking on there? Oh, hi, Sarah. I will come back to you, Sarah, on that and get an answer. I know there was discussions within HIP. I know there was some difficulties in terms of identifying products that fitted with Core 20+5, but I don't recall how it was concluded, but I will find out.
Lovely, thank you. That'll be really useful. Thank you. Sarah, you've got your hand up.
I have, yes. Thanks, Chris. That was a really fantastic, speedy update, but really on point, and a couple of questions and sort of reflections. So I'm really keen to have a look at that productivity website and how you've linked all of that, because we've done something similar with our trust improvement plan, with mapping the various pieces of NICE guidance to it. So I might be able to pinch something from that, so that's really good, and thank you for that. What I was wondering is about is there any discussion or going on with regulators and CQC about, sort of in years gone by, that there'd been a big emphasis on compliance with NICE guidance and evidence and compliance, but now with the changing space and things are moving at such pace, so there's a little bit around what the regulator might expect of organisations moving forward, but also with some of that legacy, the older guidance that may be getting updated or may not, might be not getting tweaked that much. So it's all that where we focus and prioritize our efforts around the improvement and the assurance, and instead of this potentially slight the volume and trying to get compliance against 1,400 pieces of guidance and tens of thousands of recommendations.
It's an impossible task, isn't it, in terms of how can you ever be confident that you're compliant against. I think you talk about thousands of recommendations, there's actually thousands of pieces of guidance, let alone the recommendations, and that reflects a conundrum of evidence coming into the infodemic of evidence, if you will. The appetite that we all want to be evidence-based, but our capacity to actually use it is a bottleneck. I think two things. As far as NICE is concerned, what you'll see is less guidelines coming out from NICE in terms of the traditional clinical guideline, and you may have noticed that already. What we want to do is, again, that focus on what is really most important, and obviously the eye of the beholder is really important. Obviously, it's a difficult thing to do, but focusing, being more closely linked to NHSE. What we will have, I think, is a topic suite of, the big areas. Then you can think of what, mental health. I know you can break that down, but if you think of cardiovascular, and there'll be about 10 of those, I think, where we'll be looking to make sure that guidance is probably not lots of new guidance, but guidance is kept up to date more frequently. Other guidance will be subject to a kind of monitoring, really, and that may be updated, but you will see less updates of some of the stuff that doesn't meet those kind of core areas, if you will. There's a cost to doing that, but we hope the advantage will be that it's more manageable for people such as yourselves. And then how the guidance looks is a second question. How do we guide people to find what they need when they need it, rather than the mighty PDF, if you will? And there's been quite a lot of work, quite a lot of internal prototypes about that, but I would say we're probably not quite there yet. But we recognise that the PDF with 100 recommendations is probably had its day, shall we say. As far as CQC is concerned, they don't look obviously any longer at systems of NICE compliance and haven't done for a while. We meet with them quite a lot, quite frequently, and I guess what we're trying to work with them about is using NICE guidance when they look at a particular theme, safe and effective, or NICE guidance can be a good, demonstrating you use NICE guidance is a good measure, or possibly proxy measure of how you do that. So making sure that the inspectors are cognizant that when they might ask a question about a particular piece of NICE guidance rather than your system, I think is the way to go. So we've got a lot of discussions going on with them at the moment about supporting adult carers, because that's something that's of interest to them. And they've got a whole framework from what they call kind of me questions and statements that they're looking at from the carer perspective, but the guidance is still a useful source of assurance and evidence. So it's particular pieces of guidance, I guess, that we would expect and hope them to pick up. Is that half clear?
It is, yes, very. That top 10 almost that you were talking about. Yeah. Do we have a timeline of when we think that might be identified?
I think again, it's all a little bit fluid, and I'm a bit cautious about giving a date, but I would say probably by the autumn you'll hear more from NICE about that.
Great.
But you don't have to be you don't have to be a rocket scientist, I think, to kind of, if you took a stab at it, you'd probably wouldn't be far wrong if you think about the things that probably occupying most of your time would be those.
Sure. Thank you so much. Really, really helpful.
Lovely, thanks, Chris. And that's really handy to know about that. See the way CQC are now looking at the guidance, because that really puts the focus on patient care, doesn't it? Rather than are you following your NICE process properly? So that feels right. Feels the focus is right there. Thank you. Helen Outhwaite from Transformation Teams just popped in, Chris. It'd be great if we can get our speakers today to also quickly post on the NHS Futures platform for the Taking Action on National Clinical Audit community around any new learning, new work signposting for us all, so that we can actually be equipped to take that action. That'd be brilliant. Thank you. Quite a few bits in the chat there, Chris, as well. Might be worth you having a quick look at.
Yeah.
Thank you so much, and we may well invite you back in for December meeting, then maybe for an update.
Yes, what I would I hope it's been all right. I've never done a presentation from the car before, so it's felt kind of slightly strange. So I was I hope it was kind of not too rambling. I hope it's of some interest. I'm normally a little bit more polished. What I would say is some of the points there, I know that some of you link in with the regional networks and my colleagues in the field team are there. So it would be a good opportunity they're more than happy to go into specific things in a bit more detail if you want. And myself or Joe, quite happy to come back in December if that would be of value, and perhaps be a little bit smoother.
No, it was brilliant, Chris, and you delivered it really smoothly. It was really informative. You got some positive comments coming through on the chat there. It was fantastic. So thank you so much for joining us from your car and giving us your time.
Well, I'm
brilliant.
Thank
you.
I'm going to open the car door now because it's getting quite warm. So
yeah, thank you so much, Chris.
And okay, thank you all.
Brilliant, thank you. Okay, that's excellent. So if you do have any more questions, just post them, because we will pull that Q&A together like we normally do, and obviously get our key speakers to try and give you some responses there as well afterwards. So if you think of anything since Chris has been talking, so just pop it in. So I'm probably going to spend about 5 minutes just quickly looking at Clinical Audit Awareness Week before we move to any more questions at the end. So get your thinking hats on whilst you've got us all in the room in terms of questions and queries. So last week then we held Clinical Audit Awareness Week 23. Thank you to everybody really that engaged with us across that week, whether it was a key speaker at one of the Lunch and Learns, winners of the Audit Hero Awards, people that submitted entries to the awards. We did see a difference in terms of the quality of submissions this year, in terms of it's increased that quality of what's being submitted. Whether you were attendees at any of the Lunch and Learns, National Clinical Audit providers, commissioners, providers of health and care, you were all there with us, and it was a really good week. So hopefully raised awareness to how, when utilising effectively, clinical audit can actually make such a big difference to really improving patient and service users' health and care for all. So if we have a look at the next slide then, Sonia, it's just a case of pulling out some key points really from each day from the Lunch and Learn at this point. So Monday, obviously, we covered patient safety. Hester Wayne came, the head of patient safety policy at NHS England. She was our key speaker. She challenged us all to work closely with our patient safety specialists to really add topics to our local clinical audit programmes, and stretching us further to look at including patient diversity data as well in our measurement, because as we know, inequalities and patient safety are linked. Hester announced Robert Oakley, one of the senior pharmacists, as the clinical audit hero for patient safety, looking at vancomycin continuous infusion in adult critical care. It was a really good example of a project that followed on nicely from Craig Short sharing his example of QI within clinical audit at a webinar that had been held in the morning. It was lovely to see both examples on that one day where it was topical for us in terms of other QI techniques and tools that were brought into that, actually understanding our data and making the right improvements to patient care. Tuesday, Bren McGowan, who's the policy advisor at Healthwatch, joined us. He was our key speaker and gave us some top tips as well for involving patients and the public in clinical audit and wider improvement work. Engaging, not just involving, making sure that they were participating. It's not tokenistic, or it shouldn't be. And he pointed out to us that we're not on our own. We're all trying to do this effectively within our own organisations. There's people out there willing to get involved and willing to engage. And we're also getting more examples and case studies now that are being shared to kind of inspire and motivate us all to have a go back in our own organisations. Kim's already prompted us early today, Kim Rezel at HQIP, to keep sharing those examples and sending them into her. And obviously we've got the forums as well. And if we're doing it in terms of our national clinical audits, it'd be really good to see that on the NHS Futures platform as well. So from a PPI perspective then, we had Joint Audit Heroes announced as the Epilepsy 12th Youth Advocates at the Royal College of Physicians for Child Health, and the side-by-side group at the Solent Academy, and highly commended going to Southport and Ormskirk Hospital NHS Trust. Wednesday, we saw health inequalities topic, and we had Dr. Aoife Malloy, Senior Clinical Advisor on the National Healthcare Inequalities Improvement Programme at NHS England. And Aoife shared a lot with us all around the Core 20+5, including the Core 20+5 for children now, highlighted the mapping that NICE have undertaken that Chris has just mentioned as well. So definitely worth going and have a little look at that on the NICE website. And she also signposted us to 5 new e-learning modules that have been launched to support us all in the implementation of the Core 20+5, covering inequalities. Each module only takes 30 minutes and it's accessed via the e-learning for health platform. She also announced our winners for the Health Inequalities Clinical Audit Hero Award. I'm struggling to get my words out now. Sandwell and West Birmingham hospitals looked at assessing the health needs of unaccompanied asylum-seeking children. And then we had Michaela Ward, who was a trainee GP also at the same organisation, that was looking at caring for patients in ED who are homeless or socially excluded. So there were some really good examples there of sharing some fantastic projects looking at health inequalities. Thursday, we looked at effectively influencing change at organisational level, we had the Making Data Count team at NHS England joined us again, Deborah Cundy, and talked to us about key ingredients for effectively influencing change at that organisational level around having key champions, collecting that baseline and then that continuous monitoring of metrics, making sure that we've got engagement at all levels and making changes when we see that unwarranted variation, and making sure that we have understood it and we're celebrating those achievements and we're placing that emphasis on outcomes. We had 2 joint winners for influencing change, Amy Baker from the patient outcomes team at Cambridge University Hospitals, and then Ella Howard, who's an assistant psychologist at Cambridgeshire Community Services and a highly commended winner as well, again from Southport and Ormskirk Hospital, looking at delirium guidelines and the Keep Me Here campaign. Amy Baker shared an example of how they'd developed their own local national clinical audit benchmarking tool with all their national clinical audit data, and I know, Helen, you're going to explore that a little bit further around the taking action on national clinical audits, so we can learn more about that as a community. And Ella Howard was looking at record keeping and looking at the psychology behind behaviours to try to improve the standards as well. So again, there were 2 really good examples of projects that had made change on an organisational level. Friday was sustainability, and we had John Ashcroft, Director of Pathways at NHS England, who spoke to us all about NHS impact and the new single improvement approach and priorities that will be shared by the new National Improvement Board, and of course the Leadership for Improvement programme that will be developed for us all. John also announced the Clinical Audit Hero for Sustainability, which again was a team from Sandwell and West Birmingham. The organisation did submit a large amount of projects, and they were written up very strongly, and obviously were really good worthies of our winners and highly commended this year in a number of categories across the week. They looked at increasing the use of total intravenous anaesthesia within theatres, which was better for the patient outcomes, and it was also better for the environment. So the recordings for all the lunch and learns have been recorded, and we will make those recordings available for you as soon as possible via the NQICAN forum and the NQICAN website, and also the HQIP website as well. But if we just move on to the next slide, we obviously undertook some interactive evaluations which Marina set up for us and led on, and we obviously had Jordan and Layla helping us throughout the week as well as Sonia. Feedback was pretty good. We obviously had a higher uptake of people filling out the evaluations this year by doing it interactively within the session than last year. I think, Marina, you were saying it was over 40%, wasn't it, that participated in the feedback, which was brilliant.
Yeah, just shy of 40%. Yeah, really positive responses. Yeah,
it's really good. We obviously need your feedback because we want these lunch and learns to be valuable for everybody that's participating. We want you to take away that key information, those key top tips, and really take it back to take forward in your own organisations. So if anybody does have any feedback post the week, do please send it into the NQICAN email or directly to myself and Marina as well. So we've got some initial feedback that was coming through already in terms of having the Menti link on a slide at the beginning of the meeting rather than at the end, so that people can be thinking about it as they go through session. I think it was difficult for some people to pick up the QR code on their phones, as some phones are slow. So if we share that earlier on at future events, we'll look at doing that. We've been asked to combine all the discussed links through the sessions maybe into one overall page for people to view on the forum, so we'll look at doing that. And I think some of the Sun members, the service user network through Kim at HQIP, have asked also to receive some of the comments from the chats and the mentees as well, so we'll share that with you, Kim. We are obviously tasking our regional network chairs this afternoon to be coming out to you all as members to make sure they're collating the impact of Clinical Audit Awareness Week in your own organisations, so we can feed that back into the evaluation of the lunch and learns at the September meeting as well, and we'll talk to our chairs about that in a bit more detail this afternoon. We saw loads shared on Twitter during the week. We collated that into daily Clinical Audit Awareness Week blogs, that if you didn't see them coming out on Twitter at the time, they're also available on the NQICAN website. So do please head over there to have a look at that as well. So if we just have a look at the next slide, I think we've got a lovely picture of some of the activity that was captured on Twitter for the week. So watch this space, I suppose, because we will be now over the next few weeks coming out through the regional chairs to ask you really for your feedback in terms of the impact that this has now made on your own local communities, really, in trying to increase that awareness and focus on making sure that we're improving health and care for all. And then I think that's it, and we'll move into questions from everybody. If anybody's got anything else to add that we've not asked as we've moved through session. So if anybody wants to pop their hands up, I'm just going to do a quick check on the chat. Okay, Carl, do you want to go?
Make sure that's down there. That's great. So no, thank you on behalf of everyone in our networks for everybody who's organised last week, because I thought it was an excellent week and a great celebration of clinical audit and everything positive that we can do. In terms of the first session of the week, which Craig spoke very well at, Craig East Midlands Chair, I was just a bit concerned that the messages with so many people in the audience around that there was 400, I think, on that call, and the first speaker did talk about clinical audit being more of an assurance process, and the improvement guide of Langley, it doesn't talk around clinical audit, etc. So I think there's an opportunity to, with the NHS impact work, to really, hone in on what Dr. Decore was saying and say about how clinical audit is pivotal to everything we do. And so I think that's just a good opportunity for us to continue there and make sure that the Q network are aware of what we're doing as well.
Yeah, I think that's a really valid point, Carl. And I have met with Claire post that event, Claire from HQIP that was organising that alongside NQICAN and the Q community members. So we've got quite a bit of feedback coming in from there, and obviously a lot of activity that was in the chat from those of us that were on the call from that are working very heavily with the clinical audit programmes in our organisations. So I think there will be some follow-on events coming from that initial one, really, just to get across a lot more about clinical audit for improvement. And I think Craig's presentation was fantastic at that event, and I think actually that did get across. So although the first speaker, there were a few negative comments around clinical audit for improvement, I thought Craig's example was fantastic in getting across how we're just bringing in more QI tools to the clinical audits to really make that difference to patient care. So if anybody didn't listen to it, that recording is available, and I'm sure Craig would be hopefully willing to share his example of that project as well across our forums as well.
Yeah, I thought Craig spoke very well, and that was just a shame because it was a bit disparate to the previous speaker. But yeah, I mean, Craig's doing some great work up in Mansfield area, as we know, sort of thing. Thank you.
Yeah, and I think Craig's just popped in the chat as well, Carl, about a follow-up session and looking at some of the questions and concerns raised, and Claire did confirm that was going to happen as well. So thanks, Craig, for that. That's really good. Yeah, but worth raising actually, because at least then we can assure the community that we're feeding into that piece of work to really get across that clinical audit is for improvement. So have we got any more questions at all whilst we're on the call? Thank you so much for attending today. I know it was quite a big ask after the commitment last week for all the events and things, wasn't it? But obviously, if you know of colleagues that haven't been able to attend today, obviously it's been recorded and you know where to go to get the links, because obviously we've had quite a lot of valuable information shared today that we obviously need to take forward within our own organisations as well. So please do direct people to where the recording and the slide packs will be via the forum as well. That's brilliant, thank you. So I think has any of our key speakers got anything else they want to add before we close today? Not seeing any hands come up, so I think we'll thank you all for your time. Hopefully that's been useful for you. Next open meeting's 20th of September via Teams, 10 till 12. But obviously we'll have activity going throughout the summer months as well. And obviously we've got that next webinar on the 19th of July through NHS England in terms of taking action on national clinical audits. So please do register for that event as well. Look after yourselves and keep interacting with us via the Futures Futures platform, the NQICAN forum, and obviously through your regional networks as well. Thank you and take care. You've all gained 2 minutes back.